Hi, my name is Tara Davis. Today I'll be presenting on a pilot study, the deployment of web-based self-management education in an underserved population. Again, my name is Tara Davis. I'm the Director of Community Health at Rimidi, which is a healthcare technology company located in Atlanta, Georgia. At Rimidi, we specialize in the development of platforms for disease management and prevention. The learning objectives of this presentation are to, one, demonstrate an overarching understanding of how people consume health-related content via the internet. Secondly, I would like to discuss the use of a web-based education tool to increase access for patients with diabetes. Lastly, I'll identify the components of an effective web-based self-management education program designed for vulnerable populations. The purpose of the pilot was to evaluate the deployment of a web-based self-management education program, which was moderated by a certified diabetes care and education specialist in populations that are disproportionately affected by cardiometabolic disorders, including diabetes. The first thing we had to do with the pilot, quite frankly, was to disprove the notion that people in vulnerable populations do not have access to technology. The first way we disproved this was, one, to provide data supporting otherwise, one being that the third most common use of the internet is searching for health information. Another being that 70% of Americans making less than $30,000 a year have smartphones. And that percentage significantly increases if you include additional information devices like desktop, laptops, and tablets. The other way we disproved it for the purpose of this pilot was whenever I was actually in a room with potential participants, patients, and providers, I would ask the audience to raise their hand if they have access to a Netflix account. About 60% of the room would raise their hands. I would say, keep your hands raised if you have a Facebook account. 90 to 100% of the participants, providers, whoever was in the room would raise their hands. And I would then say, well, there you have it. If you can access Netflix and or Facebook, then you can access technology to help you improve your health outcomes. And in those few and far between instances where everyone didn't raise their hand about the Facebook, they were one relative, one friend, one loved one away from access to technology. So that let us know that this was possible in this population. So the pilot actually took place across 4 different locations, but for the sake of this presentation, we're only going to focus on 2. The first health opportunity target population was Grady. The Grady Diabetes Center is the largest outpatient diabetes center in the Southeast. On average, Grady Clinic treats nearly 14,000 patients annually, and in 2018, most of the patients seen were insured by Medicaid, Medicare, or uninsured. Our second health opportunity target was the Tri-Cities area of Metro Atlanta, which is comprised of 3 cities, College Park, East Point, and Hapeville. Unfortunately for the Tri-Cities area, there's a 13-year life expectancy gap compared to more affluent areas of Atlanta. Some of the barriers to care, like many communities, are time off work, lack of transportation, no local health services, and the community profile was mostly non-white. The household income of less than $35,000 annually was made up about 49% of the population, and then about 37% of the population received public health insurance. So the pilot took place at the Grady location over a 9-month period from February 2019 to November 2019. In the Tri-Cities area, the pilot took place for 3 months, from September 2019 to November 2019. The reason being is that we actually piloted 2 different courses here. The first course, Diabetes Self-Management Education and Support, was piloted at the Grady location. The second course, Weight Management / NASH Prevention, which is fatty liver disease, non-alcoholic fatty liver disease, was piloted at the Tri-Cities location. Reason being, the previous year in 2018, we piloted the DSMES course in Tri-Cities, and it was very successful. The purpose here is to show that chronic disease management can vary across disease states And part of that also is prevention. So that's why we wanted to introduce a weight management and prevention course in addition to diabetes self-management education. We had a health educator to moderate both courses. And upon completion of the course, web-based questionnaires obtain feedback regarding participant experience. This is very important to us as we are constantly doing iterations on the course and want to ensure that it's something that participants find enjoyable as well as beneficial to their health. Recruitment. So the Grady recruitment was handled by brochures and advertisements in the waiting room areas. We also did promotion during their in-person classes, which were held every Wednesday, well, 3 Wednesdays a month. And then we had 2 second-year medical school students who actually talked to patients while they were in the waiting room, as well as in those in-person classes, because even though we are using technology, we understand that people are essential to changing health outcomes, and that technology just maximizes the potential of those people. So people are a very important component. To that effect, our recruitment method for Tri-Cities was the use of 15 high school students that we call the community health ambassadors. We brought the students in, we trained them on the web-based platform, and then we sent them out into the community to recruit and serve as virtual support for community members. So the design of the online health education is the same for both our diabetes self-management education as well as the weight management and NASH prevention. It's accessible via any internet-capable device, and it's comprised of a set of short educational videos, so 5 to 10 minutes videos from doctors, nurses, health educators, and even patients. Each organization receives a unique login. And then there's the comment sections where patients and health educators have open dialogue and promote support. Oftentimes, the health educator would input prompts to make sure participants were engaged and had a basis for a conversation taking place in the comment section. The web-based DSMES course, the course curriculum is the same as the American Diabetes Association and the American Academy for Diabetes Educators. And it's really 8 courses, but here we have 6 listed. The 2 not listed are the introduction to diabetes, and there's a course on healthy coping, just dealing with the emotional well-being of patients with diabetes. The weight management course was 6 lessons, and it covers everything from staying on track to the truth about diets to being active. And some of these courses, some of the lessons were similar in both courses, but still the content was different. The web-based DSMES course had 2 hours and 30 minutes worth of content, while the weight management course is 1 hour worth of content. The participants were allowed to complete the course at their own pace, anytime from enrollment to completion of the pilot. So it was self-paced. Even though they have a time tied to each course, they were self-paced. I also wanted to just briefly cover that the eligibility criteria here were ages 18 years or older, and that participants had the self-report history of type 2 diabetes or pre-diabetes. They had to have a valid email address and verbal fluency in English or Spanish. So all this content is also offered in Spanish for both the weight management as well as the DSME. The results. So at the end of each lesson, there were quizzes, short quizzes, 5 to 7 questions. We did this because we wanted to ensure that the participants remain engaged and actually retain the information that was being shared through lessons. Happy to report that participants completed the quizzes and passed the quizzes. You will notice there is a descending trend in some of the lessons completed, which is because we did not obligate participants to complete the course. They could start and stop at their leisure, and completing was also their choice as well. So we did have a little drop off there. Summary of results. So at Grady, we had 368 patients create DSMES accounts. And then we considered a patient enrolled once they went in and completed the first social demographic survey and provided their health information. To that effect, for Grady, we had 168 participants enrolled in the course. And of those enrolled, 73% stated they had never participated in a diabetes education course. So we know that our course increased access for health educators to reach even more patients. There was a 51% completion rate, which was a 20% increase from the in-person attendance at Grady's courses that are offered every Wednesday, 3 Wednesdays a month. At Tri-Cities, we had 212 participants create the weight management NASH prevention accounts, and there was a 93% completion rate. The use of the high school students is just very effective, and it was very essential to the success of this program. I actually have detailed the Community Health Ambassadors Program as well as the results of all these pilots in white papers. And at the end of this presentation, I'll provide my email address. You can feel free to email me, and I'd be happy to share with you those white papers, which detail the Community Health Ambassadors of Tri-Cities, as well as the results from other pilots locations not shared here. So in conclusion, we saw an increase in the number of people with access to chronic disease management and prevention education in an underserved population. Participants and clinic staff, again, people are actually responsible for improving health outcomes. Technology just maximizes the potential. So we wanted to make sure that we got feedback not only from the patients and participants, but also from the staff responsible for encouraging people to sign up and participate. And both reported high satisfaction with course content and implementation measures as well. Again, that information is available in a white paper as well as a report. Lastly, the program helps educators expand the reach of education, which is so important, especially today in our current environment, that health educators need to have additional resources to reach people. They are essential. We need them, and we also need to supply tools like this to ensure that they can keep participants encouraged, even if it's virtually. Thank you so much for your time. For more information, please email me, tara@rimidi.com. I'd be happy to share any additional information on the white papers or the techniques used, the Community Health Ambassadors Program. Just email me at tara@rimidi.com. Are there any questions? Thanks again.